All right. So this is our Friday afternoon Pulmonary Journal Club. So just the overview. We're going to discuss about the burden of smoking and lung cancer, and do a journal critical appraisal, and then comments and discussion. Again, this is a 2011 New England Journal of Medicine that compared low-dose computer tomography with chest X-ray to see if that has any effect on lung cancer-related mortality. So the American Cancer Society usually used data from all cancers that happened the previous years, and they use that to estimate the number of cases for that upcoming year, and then the number of mortality for the upcoming year. And this is what they anticipate the number of cancers would be by each state. When it comes to Michigan, it's anticipated 57,420 new cancer cases. Again, lung cancer is the most common cause of cancer in the world, 1.8 million new cases, and then 1.6 million deaths in 2012. In 2015, there's about 220,000 new cases of lung cancer is expected to be diagnosed. It tends to be a disease of the old people. 82% of those patients are 60 years and older. Interestingly, a survey in 2011 showed, that Kentucky has the highest age-adjusted incidence and Utah had the lowest, and that goes along with the prevalence of smoking in those prospective states. Again, lung cancer costs about $12.1 billion a year. And then when you add lost productivity due to early death, that adds to about $36 billion. So that's a huge amount of money. If you take the whole incidence of cancer that's anticipated for 2005, you will see that estimated new cases of lung cancer, again, there's 14% of all new cases and in females, and then 13% of all new cases in males are expected to be lung cancer. But when you look at the estimated deaths, again, lung cancer is the number one cause. And then this is just when you look at people by age. This is a study that looked at from 2009 to 2011 to estimate, what's your probability of getting cancer, all sites versus, specific sites based on your age. And when you just look at our lung cancer, again, your incidence of probability of getting a lung cancer gets very high, to 1 in 64 when you're between 60 to 69, and then 1 in 20 when you're above 70 and older. When you look at the history of smoking and tobacco use, it's very interesting because tobacco has been used for centuries and we don't really have this much incidence of lung cancer. Now you might say, well, people were not living that long in those days, and that's why probably we didn't get the lung cancer. Also, you can also say, cigarette came along the way, which made this really bad carcinogenic stuff to be provided in a small amount, in large amount, that kind of intrigued people to using them more and more. And you can see that there's more usage of those in the 1950s, 1960s. And then when you look at tobacco use and lung cancer related days, you can see that in the 1940s and the 1950s, that's where the peak tobacco use was. And then you can see that the mortality related to lung cancer kind of lagged behind by about 20 years, and it peaked in the 1980s and 90s. And then the same thing. It's this graph is mainly meant for male, but I think they're extrapolated for female. Now this is an advertisement in the 1940s. This is Ronald Reagan, saying, I'm sending this certified to all my friends. This is the merriest Christmas only a smoker can have. And that was, smoking was very prevalent in those days, and it was, considered to be healthy. And there was people. There were in the 57, I think the Surgeon General actually said, well, smoking is not really healthy. But unfortunately, it was kind of went under the radar, and then the tobacco companies went really good into commercial, and they advertised it. Then smoking tobacco sale went up. But in 1963, the U.S. Surgeon General announced that smoking can be cause illness and death, and it should be the government should take action. The interesting thing about it is that most of the people on that committee were smokers, including the Surgeon General, who actually has to quit smoking 2 months before he made this announcement. Then it comes, no more smoking. Later on, we said segregation between smokers and non-smokers, and then now we're at the point where smoking is not allowed in a lot of places. So when you look at the trend in cigarette smoking from the time, from the 1985, to 2011, you see there's a significant downtrending of smoking, but there's still about 20% male and about 25% of female that are still smokers. That adds up to a significant number of people. When you look at high school students, male high school students, you can see the trend of smoking over time is actually also declining, and this is for females the same. When you look at overall lung cancer, 90% of lung cancers are attributed to smoking. The others are radon, and then some occupational exposure, and then pollution. When you look at the relative risk based on the amount of cigarette you smoke, the higher the pack year smoking history, the higher the relative risk of smoking, of cancer. How about those who quit? Those people who quit. The risk of again lung cancer gets lower, but not as low as non-smokers, and so it takes them a long time even before they even get close to non-smokers. So again, in 2005, when you look at the estimated number of deaths by cancer, lung cancer is higher than prostate, breast, and colorectal cancer combined. This is really important slide. The most important thing that determines survival in lung cancer is early diagnosis. You can see that this is looking at their 5-year survival. Those who were diagnosed at stage 1 has 15%, 54% 5-year more survival, as opposed to 4% in 27. Those are who has regional or distant metastases. So to summarize, in 2015, again, there will be more deaths from lung cancer when you combine prostate, breast, and colorectal cancer. Again, up to 90% of lung cancer is attributed to smoking. And we've noticed that the trend in lung cancer tend to lag by about 20 years to the trend of smoking. Again, the likelihood of lung cancer decreases with smoking cessation, but again, even for people who abstain for more than 40 years, their risk is not even as good as never smokers. When you take current status of the number of people who are smoking, up to 94 million people who are either current smoker or former smokers are at a higher risk. Despite advance in surgical, radiation therapy, chemotherapy, again, the long-term survival rate still remain low, and clinical stage again plays a major determinant in terms of outcome. So knowing that we have 94 million people who are former or current smoker, and then when you add people who are secondhand smoke exposed, you have a significant number of people who are at high risk, and what to do about that. And there has been previous studies in the comparing chest X-ray with routine care, and there's the prostate cancer, lung cancer, colorectal, and ovarian cancer study that compared usual care with X-ray. while that test was going on is when they started doing this study. And so that the reason why they chose low dose CT scan versus chest X-ray is because the Plaquemine trial was using usual care versus chest X-ray. So if they don't use chest X-ray and usual care, then there will always be a question whether, if chest X-ray made any difference. So this is a randomized clinical trial of lung cancer screening. What they did was they did chest radiograph plus sputum cytology to see if that there is a randomized clinical trial in the past that showed, again, with chest radiography with plus or minus sputum that didn't really show any mortality benefit. But again, we have this advance in multi-detector CT scan that made exposure to radiation much more acceptable. So we say, well, why don't we try CT scan? Again, there are some observational study with low-dose CT scan that showed better detection of nodules, again, but there has been any randomized clinical trial. Again, this is the study preview. Basically, they took people who are smoker or former smoker, they screened them, they looked for adverse effect of screening, they did early lung cancer, those who had early lung cancer detection got treatment, and then they looked at the outcome, either mortality, overall mortality, mortality related to lung cancer, quality of life. Again, it's a multi-center randomized clinical trial, collaborative between National Cancer Institute and the American College of Radiology. The recruitment was done at 33 screening centers, and Henry Ford was one of the centers. They used block randomization, what they stratified people by age, sex, and screening center. And then within that block randomization, they also randomized people so that the similarity between the group would be the same. Again, they enrolled patients from August 2002 to April 2004, while the screening was done from 2002 to September 2007, and they followed patient until December 2009. The inclusion criteria: eligibility, you have to be 55 to 74, 30 or more pack-year history of smoking, or former smokers who quit within the previous 15 years, and then anybody with any sign of cancer, either hemoptysis, previous diagnosis of cancer, or unable to sign informed consent and unable to lie flat to get a CT scan. And these are, that was the eligibility, and then this is the exclusion criteria. And some of the important things, they did exclude people who are on oxygen, but most of the others are people who are already known to have possible lung cancer. Again, they had a total of 53,000, 23 in one hand, 26,000 in one, in the low-dose CT group, 26,000 in the chest radiography. They went again 3 annual screening starting from the day of randomization. The chest X-ray was interpreted by the radiologist who first looked at the image and then compared it with the other. Importantly, the diagnostic workup was determined by the participant PCP. The radiologist did give some recommendation, but most of the management was done by the primary care. Again, some centers did develop some guideline, but there was no algorithm. This is how they interpret the CT scan. Again, negative study or negative or minor abnormalities, those findings that are less suspicious for cancer, that are, nodules that are less than 4 millimeters, that are non-calcified, and then, positives are, greater than 4, lung consolidation, obstructive atelectasis, all those things. And then those in between that are, suspicious but important finding, but not suspicious for cancer. Again, the primary endpoint this is an intention to screen, and they're looking at the mortality difference between the two groups. And then they looked at all-cause mortality, incidence of lung cancer, and lung cancer case survival. Again, this is an intention to screen. They did meet the sample size that will give them a 90% power to detect a 21% decrease in mortality, and that's how they calculated the person year and all those numbers, which I didn't understand. Uh, in terms of the results, so the vital status, they actually followed very well this patient, 97% in the low-dose CT and then 96% in the radiograph. So they know up to the end of the study, they knew where they are. If they died, they actually use their social security number to find out what they died of, and they did have a good extensive follow-up, and they did have a good compliance, 95% in the low-dose CT group and 93% in the radiograph. And then also, I think the most important thing is that they have very low contamination rate. The number of people who had CT, who were in the radiography group, who actually end up getting a CT scan was about 4.3%. And when they did their power calculation, they anticipated 10%, so that's way lower than what they expected. And then the median duration was 6.5. Again, in terms of the groups, they're stratified based on their age, sex, race, and then smoking, whether current and former smoker, and it's pretty much identical in both groups. Again, I already discussed this, but the 53,000 total was 26,000 in one group and then 26,000 in the other group. This is the result of after the 3 screening they did, and they have about the average people who had at least one positive, 39% in low-dose CT, in the low-dose CT group, and then 16% in the chest radiograph group has at least one positive result. When you look at it, and those who actually lung cancer was not confirmed, you have a very high false positive rate, 96% in and I think 95% on the other one. And then the good thing was, though, even if they have high false positive rate, the majority of the patients were followed by imaging, so they didn't really go through under intervention that risked their life. So they did conservatively. I'll pass that. All right, and then when you look at the bronchoscopy, and then the surgical, it's a very small number of people that actually got that, like 4% and like 3%. So usually it ranges between 2 to 5% of those people. So in general, when you looked at it, 24.2% positive screening in the low-dose group, and then 6.9 in the chest X-ray. When you look at the overall the 3 years. Then you have false positive rate of 96% in the low-dose CT group, and then 96.5% in the chest X-ray group. And then this is lung cancer stage by the screening. Really important thing is that a lot of the patients on the low-dose CT group, the majority of them are identified on either stage 1A or stage 1B. When you look at the stage 4, you have a little more stage 4 diagnosis in the chest X-ray group as opposed to the low-dose CT group. Based on those numbers, they calculated that low-dose CT scan has a 93.8% sensitivity of picking up lung cancer, and it has a 73.4% of picking up specificity, which makes it a good screening test. In terms of the adverse event, again, at least one complication. They define major complication as respiratory failure and intubation, all those big things, and then minor are those that required pain medication, that staying in the hospital, but nothing that affected their life. So when you look at it, there is very, very rare the complication rate. Now they do report mortalities, and this is just mortality that happened in 60 days after the procedure, but they're not completely sure if this is related to the procedure. Again, in the radiography group, it's about the same numbers. When you look at it by stage, again, as we said, there's a lot more stage 1 and 1B in the low-dose CT group, and then about the same in the chest X-ray, but it favors low-dose CT group. When you look at it by histology, again, you will see a lot more bronchoalveolar carcinoma, which is now called adenocarcinoma in situ, adenocarcinoma and squamous cell carcinoma tend to be the major. Again, when you look at it further by histology and what stage they are, you will see that the majority of the bronchoalveolar carcinoma, adenocarcinoma, they're all found up to stage 1 to stage 2B. So in summary, again, the rate of detection, when you look at it during the screening year, it didn't really decrease, which suggests that if you actually continue screening, you're not really you don't just screen one time and say, well, you need to come in 5 years or 6 years from now, because the high risk patients still have they still found more same amount of lung cancer with each screening time. Again, fewer stage 4 lung cancer in the low dose CT group. There was many adenocarcinoma. Small cell lung cancer didn't really show any preference to stage in both groups. Again, treatment for stage 1 and stage 2, which is either surgery alone or surgery plus chemotherapy, is pretty much the same, which you worry because primary care decide on what kind of treatment they get. So the fact that those people that were picked up earlier got almost the same kind of treatment makes the calculation for mortality benefit more reliable. Again, when they calculate the cancer mortality rate, they have 356 deaths in the low dose CT group and then 443 days in the chest X-ray group. And again, this is a graph. So based on that, they've concluded that there is a 20% relative reduction in rate of days in the low dose CT group. The absolute reduction of 62 lung cancer days per 1,000 person year, and the number needed to screen is 320, and then all-cause mortality is reduced by 6.7%. When you look at overall mortality, again, they actually looked at with Social Security and hospital record, and you can see that some of the numbers doesn't add up because they ignore them if they didn't really get a good understanding of why the patient died. So the strengths of the study is it's a randomized trial. It has a very large sample. It has high adherence, very low contamination. They did have a really good follow-up. Now, they didn't have a mandated diagnostic algorithm, which makes it more practical, because in the community there's people, primary care doctors do it in different ways. So having that different mechanism, a different way of doing it, is maybe more practical, and it can be shown in the community. The vast majority of the false positive studies were followed non-invasively, and then the complication even from the invasive procedure were rare. So things that were favoring the low dose CT screening is, again, we do have more adeno and squamous carcinoma that were found at stage 1 or stage 2, but you have again a lot more, 70% are in the low dose CT group. Again, earlier disease were detected in the low dose CT group, while advanced detected in the chest X-ray. So the weakness of the study was one of the things as a generalizable. Most of the participants in this group were younger, higher education, and then they're more likely to be former smokers. And then the other thing was, this is all done in academic center with experts. So I don't know if this will be applicable to community practice, especially when they looked at for lung cancer surgery, when they looked at the rate of mortality in the surgical intervention, there is 1% mortality compared to 4% in the general population. Now, even if this is a strength for not having a mandated algorithm for follow-up, that also says, well, would that have made any difference in the treatment, and then would that have made a difference in the calculation for mortality? Again, there is high false positive, but again, these are people that are managed non-invasively with very low risk. So when you really look at a screening test, you look at biases in screening test, and what are the most common biases? Especially like when you look at length bias, where we're detecting a disease that has very long preclinical period, and we're not making any difference in terms of the mortality. But we know that lung cancer is very aggressive and it's heterogeneous, so it's really hard to say there is a link bias. The voluntary bias, which was reported earlier, because again the participants are younger, higher education, and then they're former smokers, so they're more likely to follow up, more likely to volunteer to do stuff, so and more likely to adhere to treatment. So that may be a limiting factor. Another thing will be a lead time bias, which we'll talk in a bit. And then overdiagnosis, again, is just picking up things that might not make any difference. But we all know that early diagnosis of lung cancer is important, and lung cancer is very aggressive. So this may not be a big thing. On top of that, they have about the same number of cancer diagnosed in chest X-ray group as opposed to low-dose CT group. The only difference is that you picked up earlier cancers in the low-dose CT group. So I don't think overdiagnosis has anything to do with that. In terms of lead time bias, so if you look at this, for example, if you have a disease that started in 1985 and you get diagnosed in 92 and the patient died in 95, you have a 3-year more survival. And then if you have another intervention that able to diagnose it early and the patient still died in 95, you're going to say, oh, he lived 6 more years, when in fact it didn't really make any difference. So again, that's the lead time bias. However, in our study, in this study or even in prior study, we already know that people, when they're diagnosed at earlier stage, they have much more better survival. So even if there possibility that you have a lot more stage 4 lung cancer in the chest X-ray radiography group, the importance of picking up a lot more group 1 or group 2, stage 1 or stage 2 lung cancer by the CT scan, you can infer that it has a mortality benefit. So what is the current United States Preventive Service Task Force recommendation? It gives it a B. That means they still recommend that you offer to your patient, but their population, they're saying is age 55 to 80 with a history of smoking, and it recommends an annual screening with low-dose CT group up to age 80. So this is this study was done for 3 years, but this is recommending for every year for whoever is at risk. And the question comes is, we don't have a good understanding of radiation-induced lung cancer. It's a long phenomenon, so it's very hard to assess it at this point. And then what about those patients that doesn't meet the eligibility criteria, but they are at higher risk, like a 50-year-old with 40-pack year history, or a 60-year-old with 20-pack year, or a 7-year-old with 40-pack year, but who quit 20 years ago? And then the other question is, for how long should we screen? Is it cost effective? Is the benefit outweighs the risk? And then of course, should we, when you go into the journal and when you look at the comment side on New England Journal of Medicine, a lot of the comments says, why are we dealing with this? Why can't we deal with prevention? So again, is that something we need to focus on? Again, we have more technologically advanced CT scans, so maybe we'll be able to pick up more cancer. During these studies, they have actually collected sputum samples, so they're hoping someday we'll have molecular markers that will tell us patients who are appropriate for low-dose CT, or patients who have positive low-dose CT skin that needs aggressive diagnostic workup based on that molecular study. Again, at the end of the day, I think prevention is better than cure.